Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent educational grants from Otsuka America Pharmaceutical Inc. and Lundbeck Inc.
Welcome to Medscape Education, Post-Traumatic Stress Disorder in Primary Care. Next. Today, we're going to talk about post-traumatic stress disorder in primary care, understanding roles and responsibility. Hello, I'm Dr. Lori Davis, adjunct professor at the University of Alabama Hersink School of Medicine. Today, we're going to discuss a case vignette from a previous webinar. We'll revisit that case and identify the traumatic life event, get more questions to ask in more detail, and begin to try to tease out the diagnostic considerations using assessment tools, screening tools, looking at the diagnostic criteria of post-traumatic stress, ruling out differential diagnosis, thinking about the initial treatment alternatives and interventions, and understanding when and how to refer patients with post-traumatic stress to specialty care. Let's revisit Michael R. He came in for the primary care checkup, and the primary care provider looked at the medical record and notes that the patient had been to the emergency room about 4 months ago for minor cuts and bruises following a motor vehicle accident. The patient volunteers that he has been on edge for the last couple of months. He doesn't feel engaged with his family. He's avoiding game nights, social events, retires early. And he's been having thoughts. He can't seem to get his mind off the motor vehicle accident more. It's more frequently than it was even after the car accident. Upon questioning, he says that he only sustained minor injuries in this multiple vehicle pileup, but he witnessed 2 others who were badly maimed, and he found out through the ER that they later died in the hospital. So in the primary care office, he had entered into the patient portal prior to the visit, and not only doing the depression self-screening instrument and the anxiety scale, but he had also finished the PTSD clinic checklist that this primary care provider already had in this pre-appointment screening. He scored, by the way, around 35, which is really a moderate level of PTSD. So this PTSD checklist, which you're seeing here on the slide, asks about each of the 20 items, ranking it from not at all to extremely bothersome. And so the range is about 0 to 80. And we see that the cut point around 30 or above, is a good assessment that this patient probably has post-traumatic stress disorder at the moderate level. In general, this cutoff score tends to produce pretty reliable results compared to a clinician assessment, a detailed interview. There are other screening tools for PTSD, and I encourage you to look at each of these. If you already have one in your practice, that's wonderful. You're really ahead of the curve on that. But if not, you can compare that PTSD checklist, which asks about all 20 items, to some that are shorter. For example, the primary care PTSD 5, which is really geared to primary care settings, it asks about 5 items, basically a yes or no on nightmares, avoidance, being on guard, being detached, and blaming self or others. In this measure, you're really just getting yes, no. So you're getting a cutoff. If they answer yes to 4 or more items, then it's an indication they need more assessment. There's also a shorter one called the SPAN. It's a 4-item scale, and SPAM stands for startle, physical upset, anger, and numbness. Again, that's a shorter, just a quick inventory to test it. Then there's the sprint, also an 8-item question. That gives a little bit more of a score because the patient can answer 0 to 4 on how much it's bothering them on 8 questions of PTSD. And then there's the trauma questionnaire. It's a 10-hour yes or no. So again, if they answer yes on 6 or more items, then they need more assessment. Let's think about this case of Michael coming into the office. And I realize the time is tight in a clinic. And for you as a provider to ask further about PTSD, oh boy, it can put any provider on edge that this is going to completely wreck your schedule if you have a patient start to open up about their trauma. But let me tell you, it's okay. If a patient, it's kind of like peeling an onion. If you break it open and get into the trauma, it may take a little bit of time for them to talk about that trauma for the first time. But trust me, it relieves the patient of so much anxiety. It really helps the therapeutic rapport. And patients tend to only want to talk about their trauma once, maybe twice, but they're not going to be constantly nagging you or coming in every visit and revisiting that trauma. It's kind of like pulling off a Band-Aid or debriding a wound that you open it up, it gets out, and then you can go from there. So please take a few minutes extra with patients who are complaining of not being able to shake it off, get over something that happened to them that perhaps really caused them a lot of fear that they might have lost their own life. So in this case, the patient identifies the motor vehicle accident with fatalities, pretty much open about that. Motor vehicle accidents don't tend to have as much stigma as other forms of trauma, so this one came out pretty easily. So he does have what they call criterion A for PTSD. To get post-traumatic stress disorder, after all, you have to have a traumatic stress. Now, traumatic stress could be a loss of stress to one person. They could be having a divorce or a loss of a job. Those type of stress, although big, do not qualify for the life event required for PTSD. These traumas have to have some form of a threat to life for self or others, sexual violence or assault, abrupt and accidental, unexpected death of a loved one, and other types of serious trauma that really rev up this immediate fight or flight response. Going in to the types of trauma, the diagnosis, there are several types of traumas that could be considered key drivers or more likely to result in post-traumatic stress. For example, rape, physical abuse by a domestic partner, being kidnapped, sexual assault, those type of traumas really have increased risk of developing PTSD. Also, war-related traumas such as seeing and observing atrocities, combat trauma, of course, and then childhood physical or sexual abuse are putting people at high risk for PTSD. As you can tell, those different types of traumas are a little bit more sensitive to talk about. Patients may need a little more time, but certainly it's well worth the time invested to get this trauma brought out into the light of day. Next slide. Now we're moving on to the symptoms. And the Diagnostic Statistical Manual, DSM-5, I don't expect you to have all this ready at hand, but luckily today, you can have this as a cue card to what you might be looking for. There are 4 groups or clusters of symptoms with PTSD. The first group are the re-experiencing symptoms. We're going to go into that in just a little bit. The second one are a persistent avoidant symptoms. The D criterion are the negative cognitive ideation and mood. And the fourth cluster, E, is probably what we're most classical, is the hyperarousal and reactivity group. So for the re-experiencing symptoms, these intrusive symptoms, they involve intrusive automatic memories that just tend to be barging in, not being very sensible. Recurrent nightmares, distressing dreams where they may even act out in their dreams, wake up sweating, heart pounding, having flashbacks, which is not easily distinguished from intrusive memories, but it is a momentary dissociation, a loss of awareness about where they are, and they're almost back in or really in the event, reliving it. And then intense emotional or physical reactivity to cues. Avoidance is the next cluster of symptoms. Avoiding internal thoughts or feelings. So a person might be doing all sorts of mind tricks to keep their mind from thinking about it, distracting, keeping busy, just keeping their mind focused on something. And this is exhausting for many patients. And then there's the classic avoidance of people, places, conversations, and situations that might trigger these other symptoms of PTSD. The next cluster on the next slide are the negative mood and cognition. Really having gaps in their memory about the trauma, the painful parts, losing interest in activities, some of which is avoidance, being detached or out of sync with others, and this is really starting to interfere with their intimate relationships, having emotional blunting or numbing, not really being able to feel that positive joy, love, warmth like they had, and then having real negative beliefs about themselves or the world and others. The next cluster of symptoms are hyperarousal. The hallmark symptom of PTSD is insomnia, not being able to sleep because they're more alert at night, fearful, watching for danger, irritability, anger, seeming to have a short fuse is also one of the presenting complaints. Difficulty concentrating, kind of like an attention deficit problem, because the brain is doing so much to filter and gauge threat versus safety that it's losing track of the immediate task at hand. Being easily startled, being hyper vigilant, on guard, scanning the environment, having situational awareness. And then it gets into even impulsive, reckless, self-destructive, risky behaviors. So moving on then, there are those other criteria for all major mental illnesses. And this is one, it has to be going on for a month or more. Prior to that, it's called acute stress disorder. But we really want to see before we diagnose post-traumatic stress disorder that they're not going to either undergo some type of natural recovery, which is fortunately the case for most people going through a trauma, or have some type of support to help them recover and prevent PTSD during that first month past the trauma. Then also these symptoms are and need to be causing significant distress or functional impairment, either at work or in relationships at the home. And then the symptoms are not otherwise explained by medical disorder or substance use. So here are some comorbidities or differential diagnosis of PTSD. In addition to other anxiety disorders, such as panic attacks, panic disorder, there are dissociative disorders that could be going on. Traumatic brain injury could also be part of the differential. If they, particularly this person in the motor vehicle accident, did he have some kind of head injury? temporarily dazed, confused, or temporary loss of consciousness could indicate that. Then patients after a trauma sometimes turn to substances as a way to self-medicate or regulate, and they may have either pre-existing or confounding substance use disorder. And we've already mentioned acute stress disorder in that first month. Some people might have an adjustment disorder if that traumatic event doesn't really cause other symptoms, but they're having a problem readjusting. And then major depressive disorder is frequently comorbid and could be the primary diagnosis. Okay. So the guidelines are looking over, there are a lot of reviews out that are published, meta-analyses and systematic reviews. And really, I can say most, if not all, agree that there are some evidence-based psychotherapy in the CBT or cognitive behavioral therapy domain that are first line, great evidence that it works. Cognitive processing therapy is one name. Prolonged exposure therapy is another, and EMDR, written imaginal exposure therapy. And they also agree, these guidelines and reviews, that the SSRI antidepressant class are the first line pharmacotherapy treatment. In clinical practice, most providers are treating with a combination of psychological and pharmacologic approaches. And then long-term pharmacotherapy is typically required for some type of maintenance of functional improvements. The guidelines, now you have also a multitude of guidelines, including the VA Department of Defense guideline and the American Psychological Guidelines. For pharmacotherapy, first line, strong recommendations for the FDA approved 2 medications are paroxetine or Paxil, sertraline or Zoloft. Those are the only 2 FDA approved medication. However, venlafaxine or Effexor, which is a serotonin norepinephrine reuptake inhibitor, has strong evidence with multiple randomized controlled trials. It was on the verge of FDA indication, but it went generic, so the industry abandoned that funding to push it through the finish line. But so that's why you see it in the guidelines. The American Psychological Association also added fluoxetine Prozac to that list based on some clinical trials. Where do you go when there's a lack of response to the serotonin reuptake inhibitors or the SNRI, the serotonin norepinephrine inhibitors? There are alpha blockers that modulate the norepinephrine system, such as prazosin and clonidine. There are the antipsychotics or the second and third generation neuroleptics. There are sleep agents such as trazodone. And then, of course, psychotherapy. Come back to one of the first line evidence-based psychotherapies. So these existing treatments do have side effects. As you know, antidepressants can cause nausea, headache, diarrhea, anxiety, sexual dysfunction. And so we tell them about that. Typically, most of these side effects are early onset of treatment, transient. So we might start with a lower dose as we'll look at with our case and increase to avoid these side effects. But side effects can cause patients to want to stop treatment or change treatment, so be aware. Benzodiazepines, although it's easy to use those for such as panic and acute anxiety, these are ineffective for the treatment of PTSD and can sometimes delay the recovery with the evidence-based psychotherapies. So we tend to avoid the benzodiazepines as a chronic treatment. Also, the patients quickly develop tolerance and have to increase the dose and get into higher risk. So we have one study at least that is already looking at the comparison. This is published in JAMA Psychiatry 2019, where this group of investigators and veterans, 200 veterans, were randomized at the onset to either treatment with prolonged exposure therapy alone plus a placebo pill, or prolonged exposure plus sertraline, or sertraline plus the education medication management, some support there in the clinic during a med check. As you can see, and this is a change over 24 weeks with the clinician administered PTSD scale, going down is getting better. All groups did pretty equally well. Okay, there were no significant differences between these types of treatment. Turns out patient preference had a slight edge in looking at one of the sub-analyses in recovery. So patient preference does play into improved recoveries. Now, there were some differences. For example, the early responders were more likely to be in the prolonged exposure plus sertraline group. So starting out with both of those treatments hand in hand tended to bring about an earlier response. And the rate of dropout was less in the sertraline plus education management compared to prolonged exposure plus placebo. Those who did not remit seemed to have a lot of sleeping difficulties, hypervigilant, and nightmares that may need, after this trial was over, other alternative treatments for insomnia. So what we want to do in primary care is really start to refer most cases to trauma-informed care. In the VA and university settings, and maybe in some of your practices, you have already embedded a mental health clinician in primary care to do some immediate assessment and treatment right there in your primary care team, such as a psychologist or a nurse practitioner who has additional psychiatric training, or a social worker who can begin to use some of the trauma-informed care in primary care. Then, of course, you're going to be, now that you're becoming more aware of PTSD and wanting to get patients into treatment because treatment alternatives are available, understand your patient's healthcare referral network, reach out to existing providers. How are they dealing with it? And then again, if you have an embedded social worker or nurse practitioner, maybe they could receive more specialized training to advance their skills in your practice. So what we do with patients early on is begin to educate them about their screening results, the diagnosis, encourage them to become a student of that illness. Here I have some referral sources for you with the International Society of Traumatic Stress Studies. ISTSS.org can help find a clinician in your area. These are all free to you. And also the National Center for PTSD, although it's federally funded, it is not limited just to federal government VA clinicians. PTSD treatment options are there, and a patient educational link right there, we give it to you in this Medscape educational program, is a decision aid that patients and their care partners can go through to educate themselves on the treatment alternatives. And we have some other places here. I just want to kind of give you a glimpse here that this patient was started on sertraline at 50 milligrams, went up to 100 milligrams over the first month, and then at the month 2, due to some lingering symptoms, increased to 150 milligrams. During this time, the primary care provider said, please go on this national website for PTSD and look at this decisional aid, as well as some apps that are freely available. At the follow-up visit, he was much better, but not well. So that's for your next Medscape education. We'll look at that later. I just want to give you a glimpse here. We're not promoting Medscape education, is not endorsing these, but this is the VA website called the National Center of PTSD, and these have been vetted very carefully by psychologists and a team of experts. And these are friendly apps, self-help and treatment companions that patients and their care partners can access and utilize as a self-help, looking at PTSD coach, mindfulness, CBT. We are now, I hope, approaching, after we've talked about the diagnosis, initial treatment, and referral process. We'll continue this in part 3 of the webinar, but I want to quickly get to the question and answering, the Q&A part of our program. What we have for the Q&A is, how common are dissociative disorders as a comorbidity of PTSD? It probably is also based on the type of trauma. Dissociative disorders tend to be more common, and I don't know the precise percent right off my head, but in those with sexual traumas, sexual assault, really very significant traumas that really are threatening both the physical integrity or torture, atrocities types traumas begin to comorbid dissociative disorders are more common. What is the first question to ask a patient to open the discussion about life traumas? Well, I think I would ask, have you in your lifetime experienced any life-threatening or physically threatening traumas that you've either experienced or witnessed in your lifetime? So being in this field for 30 years, I'm very comfortable about starting out with that question. You may have to find your own words to just take it as part of a history of the both medical and psychiatric problems. How do primary care providers perceive the symptoms and variety of PTSD symptoms and various aspects of PTSD? You are so right. The presentation of PTSD can be very heterogeneous. They can come in, their chief complaint can be, I can't sleep because I'm having nightmares, or I can't function because I'm having so much irritability, quick to respond, quick to be agitated, fearful, or angry. So we are at the end of our presentation. I want to thank you so much for attending and look forward. We will be getting more educational programs on the diagnosis and treatment and looking at effective treatment. What is the most effective versus first line, second line add-ons? We look forward to giving you more of these educational activities in very short segments. Hope you have a wonderful day. Thank you so much.